President Obama went to Texas this week, he made an important point that Texas, maybe more than any other state, needs Obamacare. That's because Texas has some of the worst health care disparities in the country. About a quarter of the population is uninsured. That's 6.1 million people, more than the population of most other states. 16% of white Texans are uninsured. 23% of black Texans lack insurance, and 38% of Hispanic Texans remain without insurance, which means that of all the people without insurance in Texas, 60% of them are Latino. The Texas Medicaid program, while one of the biggest in the country by sheer numbers, is also one of the most stringent. If you're a parent, you don't qualify for Medicaid unless you make close to nothing, just less than $5,000 a year for a single working parent with 2 kids. And if you don't have kids and aren't disabled, you can't get Medicaid at all. The ACA's Medicaid expansion would change that. Any adult making up to 138% of the poverty line, about $15,900 a year for a single adult, could get insured. It would mean insurance for 1 million more people in Texas. That's 1/5 of the estimated 5 million people who would get insurance if every state refusing to expand Medicaid changed their minds. But Texas Governor Rick Perry is one of the many who has refused. And now about 5 million people will fall into a gap. They can't qualify for Medicaid, and they are too poor for federal insurance subsidies. Joining me now to talk about the stubborn state's effect on health disparities is Dr. Deborah Stolberg from the University of Chicago, Avik Roy, former health care policy advisor to the Romney campaign, Dr. Otis Brawley, who's chief medical officer of the American Cancer Society, and Heather McGee of Demos. Thanks so much for being here. So let me ask this. We know that race is not biology. Race is social and political. So what does that tell us then about racial health disparities? Where do they come from?
Most racial ethnic disparities actually come because people get less than good care, usually less than good preventative care. I'm very worried about diets for young kids and how they grow up, lack of exercise. I'm very worried about not getting vaccinations. That's actually much of the root of hypertension and other things later in life is because kids get less than good preventive services. Later in life, adults need to get good preventive services as well. Treatment of hypertension. We can prevent a lot of heart attacks, a lot of kidney failure, a lot of strokes if we simply did these preventative things. We worry in this country too much about treating people once they're sick and not about preventing the disease.
So this question of preventative care is actually part of what President Obama went to Massachusetts and said when he was saying this Obamacare is like Romney Care. One part of it is it's going to provide access to preventative care services for a broader group of people. And that will bring down health care costs not only for those individual households, but also for the state, for the nation. Why then are Republican governors opting out of something that would, in fact, bring down costs?
Well, one of the things you brought up the disparity in terms of coverage among different ethnic groups. There's also a disparity in the quality of care separate from coverage. And that's one of the big challenges with the Medicaid program. So, for example, in New York State, for every dollar that a private insurer pays a doctor to care for a patient, Medicaid pays 30 cents. And so what that ends up meaning is a lot of people don't get those preventive screenings. When they get diagnosed for cancer, if you're on Medicaid, you get diagnosed at a more advanced stage of your cancer because it wasn't diagnosed earlier because you didn't have access to primary care.
Yeah, so that's not wrong, that Medicaid reimburses at something like half to 60% of what, for example, Medicare reimburses at. But that's not a reason to then not expand Medicaid, right?
Right, and it would seem like you're suggesting that the federal government should put more money into Medicaid so that it could be more generous, but I'm assuming that's not what you would say.
I think we should spend more money on health care for the poor. I don't know if the Medicaid program is necessarily the best mechanism for that because it's so structurally dysfunctional.
And what's more, in communities where a high proportion of people are uninsured, even the insured adults in that community have difficulty getting care. So I want to walk through just a couple of the disparities a little bit and kind of see the extent to which we think having more insurance or more access or something else would make a difference. So let's talk about asthma, particularly childhood asthma. What do we know about childhood asthma as a disparity and what difference it might make to have insurance access?
A child should never die of asthma. A child should never have to be in the ICU. Asthma is a treatable condition. When you get diagnosed, there are clear guidelines that your primary care doctor should be able to offer you. But treatment can be expensive. Following all of the regimens of your medication can be difficult. You need a supportive school environment. You need really a whole system to care for that child with asthma, and that's what's difficult.
There was a study published, I think it was in the New England Journal, it may have been in the Journal of Pediatrics, that showed that people who said that their children were on Medicaid, doctors would 55% of the time, if they said they had their kid had an acute asthma attack, 55% of the time the doc would say, I don't have an appointment for you. Whereas if the kid had private insurance, under 10% of the doctors would turn down those patients.
So what is the solution to that sort of, I mean, if Medicaid is the thing that at this point we know would massively expand who is covered, but you're saying Medicaid's broken. What do you see as the key solution to that?
I support actually giving them private insurance through these exchanges. So what the Arkansas model is doing is one way. It's not perfect what Arkansas did, but actually giving people the opportunity to have private coverage that reimburses doctors at a more favorable level. That'll give them that access to primary care and specialist care that they
keep
need.
healthcare costs high?
Not necessarily, though, because there's a lot of waste and, again, there's structural dysfunction the way Medicaid spends the money. If you structure the insurance product in a different way, you can actually address a lot of these problems and still pay doctors a lot of money. The problem is Medicaid doesn't allow you to do that. So what states do is instead of tweaking the insurance product, they pay doctors and hospital less because that's the only lever financially they have.
So would you have the working poor have very generous tax subsidies? Because I can't see how you can be sort of opposed to the minimum wage on one hand, not want to have any regulations around what employers do with their employees, and still say that someone making $14,000 a year should shop for private health insurance, which costs that much on the individual market.
Very different points, right? Because when you raise the minimum wage, you do some of these other things, you make it harder for people to get jobs.
Right, well, we've already refuted that.
If you subsidize, well, we haven't.
So let's say
if we subsidize our health care, that's independent.
Job.
It's independent of who hires them, right? So if I give that person a large tax credit to shop for coverage on his own, that has no impact, plus or minus, on whether that person can get hired.
Why not improve Medicaid?
Yeah, right.
Well, you'd have to make radical surgery to the program statutorily to actually.
So thank you to Dr. Otis Brawley and to Heather McGee and to Dr. Deborah Stolberg and to Avik Roy.